You are welcome to this online class. My name is Dr. Omuyiwa Awoleke. I am an associate professor in the Department of Obstetrics and Gynecology, Ekiti State University and Ekiti State University Teaching Hospital. Our topic for today is secondary amenorrhea. At the end of this class, you should be able to define secondary amenorrhea. You should be able to discuss the causes of secondary amenorrhea, understand the diagnostic flow, and be able to enumerate treatment options. And so, by definition, amenorrhea, simply put, means without menstruation, and it is the absence or the cessation of menstruation. It could be classified into primary and secondary variants, and it could also be due to physiological or pathological causes. However, secondary amenorrhea is the absence of menstruation for 6 months in a woman with previous spontaneous menstruation. It could also be defined as the absence of menstruation for a duration equivalent to 3 normal cycles for the affected individual. In other words, if a woman has menstrual cycles that are longer than 28 or 30 days, whatsoever the length of her cycle is, 3 times that one will give you the duration beyond which a woman will be categorized as having secondary amenorrhea if she does not observe her flow. Physiological secondary amenorrhea could arise as a result of pregnancy. In fact, the commonest cause of secondary amenorrhea is pregnancy. The second thing is lactational amenorrhea, and this happens in women when they breastfeed. When young girls attain the age of puberty, in the immediate postpubertal period, a number of them tend to have irregular cycles and even secondary amenorrhea. And then menopause is a clear cause physiologically of secondary amenorrhea. Pathologically, secondary amenorrhea can result as a result of disorders of the hypothalamo-pituitary axis, and these will lead to chronic anovulation. Systemic endocrine disorders are another cause or group of causes of secondary amenorrhea. Ovarian disorders, outflow tract abnormality, and iatrogenic factors complete the list of pathological causes. Let's take them one after the other. Hypothalamo-pituitary disorders. In cases where a woman is subjected to prolonged stress, physically, emotionally, or mentally, she is at risk of developing secondary amenorrhea. Rigorous exercises, especially in athletes, in ballet dancers, or in people who are military personnel, can also predispose them to secondary amenorrhea. When weight-related issues like obesity or the very important challenge wherein young ladies, being obsessed with their body image, subject themselves to extreme starvation in order to reduce their weight to desirable proportions, they could also develop secondary amenorrhea. Hyperprolactinemia is a very important pathological cause as well. And then pituitary lesions, e.g. tumors like prolactinoma, and even Sheehan syndrome, when a patient develops anterior pituitary necrosis of the pituitary gland. When that happens, then they can also proceed to secondary amenorrhea. Chronic medical diseases like diabetes mellitus or chronic renal disease can also be an important reason why they can have secondary amenorrhea. Psychiatric illnesses, including eating disorders like bulimia nervosa, pseudocyesis. And this is a situation in which a woman believes that she's actually pregnant and manifests symptoms that suggest pregnancy, when in actual fact there is no clinical evidence of such. Trauma, e.g. fractured base of skull, and cerebrospinal inflammation, like in encephalitis or following radiation, are important hypothalamo-pituitary causes of secondary amenorrhea. Ovarian disorders. It could be because of polycystic ovarian syndrome. This is the commonest cause of endocrine chronic anovulation, and it can result as one of its manifestations into secondary amenorrhea. Premature ovarian failure, for example, due to autoimmune oophorytis. This is also another important cause, alongside with tumors of the ovaries, especially hormone-producing, androgen-producing ovarian tumors. And then when there is ovarian destruction, which could happen following treatment for a pelvic malignancy, this could also result into secondary amenorrhea. In endocrine disorders, such as hypothyroidism, hyperthyroidism, diabetes mellitus, chronic renal disease, and adrenal disease, these have also been associated to different degrees with secondary amenorrhea. Outflow tract abnormalities, especially what we describe as amenorrhea traumatica. In other words, amenorrhea that follows instrumentation of the uterine cavity. When this happens, alongside with abdominal pain and menstrual irregularities, we have a situation in which the Asherman syndrome is formed. Endometritis, especially tuberculous endometritis, can also result into outflow tract abnormalities. Post-traumatic cervical stenosis also. And then iatrogenic factors, post-pill secondary amenorrhea. This follows the use of some pills or contraceptive agents to be able to reduce fertility, and this eventually can result into secondary amenorrhea. Following hysterectomy, following irradiation either of the cranium or of the pelvis, post-oophorectomy, this will remove the ovarian tissue and then predispose the woman to secondary amenorrhea. Following cancer therapy and in the use of psychotropic agents like phenothiazines, this also can predispose to secondary amenorrhea. And then side effect of hormonal contraceptives. In trying to make a diagnosis, we need to look very closely at the history, do a thorough physical examination, and cost-effective, specific investigative procedures. The history for women who present with secondary amenorrhea should focus on the menstrual history, the last menstrual period, the menstrual pattern, the age at menarche, then the sexual history of the woman and her contraceptive history. We also need to find out about her previous medical information to exclude chronic medical disorders. What drugs have been prescribed prior to presentation? Are they is the patient also on illicit drugs, substance abuse, and then exposure to chemicals, especially occupational exposures. Then the diet, changes in body weight, and the exposure to stress. And then history of physical trauma to the cranium or radiation. These are critical in identifying the possible causes of the patient's secondary amenorrhea. Then, in the physical examination, we're interested in identifying and in knowing the weight of the patient, her height, and whether the BMI is consonant with her features, and then the overall nutritional status of the patient and her physical appearance. Then the secondary sexual characteristics, are they well developed, pubic hair, axillary hair, and general hair distribution. Then thyroid gland enlargement, as in the case of hypothyroidism or galacturia. And then in cases where we are suspecting pituitary gland enlargement, we also need to examine her for bitemporal hemianopia, and then a pelvic examination. All these put together will help us to be able to classify the possible cause or causes of her condition. And then specific investigations that should be done. First is to exclude pregnancy. Like we said earlier, one of the the commonest cause of secondary amenorrhea is pregnancy. So after we have done a pregnancy test and it turns out negative, the woman can be administered progestogens, which is called a progestogen challenge test. If the challenge test returns positive, in other words, if the woman responds by menstruating, then it implies that she has adequate estrogens and a patent tract. This is not actually her menses, but this is a withdrawal bleeding in response to the administration of the progestogens. Other tests that could be done, which are of very great importance, are the hormonal tests. We need to look at the level of our progesterone, gonadotropin levels, follicle-stimulating hormone, and luteinizing hormone, because in women who have chronic anovulation, these hormones tend to be very high. Prolactin, like in cases of hyperprolactinemia, estrogen and androgens also could also help in properly classifying the disorder. Other hormones, like the thyroid function test, will help us in determining what was responsible for the amenorrhea. In cases where we suspect an autoimmune disorder, like in premature ovarian failure, then we could also screen for autoimmune antibodies. Ultrasound also is very important in identifying pelvic pathologies. Hysterosalpingogram is an important investigation that could help identify the possibility or of Asherman syndrome, intrauterine synechia being the cause. In more advanced climes, where they could also do hysterocontrast sonography, this could replace the HSG. And then in centers where there are facilities for evaluation, an endoscopic procedure called hysteroscopy can also be done. And this, under direct vision, is able to identify areas of intrauterine adhesions and possible reasons why the woman developed the secondary amenorrhea. And then imaging techniques also, like the CT scan or MRI of the skull to exclude prolactinomas and of the pelvis to exclude ovarian masses, are also of great importance. At the end, once the cause is identified, then we could go ahead to define our treatment options. It depends on the cause. One, we could just reassure, especially at the extremes of reproductive age. With young ladies who are just post-pubertal or women who are at the end of their reproductive career will also benefit from reassurance. Psychological counseling and possibly encouragement for weight gain will also help women who have developed the weight gain as a result of severe dieting. Cyclical estrogen progesterone pills can help to not only produce monthly bleeds, but can also help to shed off persistent endometrial tissue. Drug treatment can also be beneficial, especially in women who still desire to have pregnancies. Bromocriptine can help to lower the prolactin levels if they are elevated. Clomiphene citrate and gonadotropin releasing hormone agonist can also be used in cases where we want to induce ovulation. And then hormone replacement therapy. In patients who have deficiencies of thyroid hormone, thyroxine is administered. In patients who are diabetics, they will benefit from insulin care. And then intrauterine hydrolysis, intrauterine coil device insertion, and hormone therapy. This will also help to deter reformation of the adhesions, and eventually, after 3 to 6 months of use, will help to restore the woman's cyclical pattern. And then surgical exclusion of large pituitary adenomas that are not responsive to bromocriptine therapy. In cases where the woman has polycystic ovary syndrome and the facilities are available, she will benefit from laparoscopic ovarian drilling. As a reminder, the definition of secondary amenorrhea is hinged on the duration of time of the woman's cycle. For those who have monthly cycles prior to development of amenorrhea, they need a period of 6 months before we can make that diagnosis. For those with irregular cycles, we need 3 times the duration of their normal menstrual cycles to be able to make a diagnosis of secondary amenorrhea. The causes of secondary amenorrhea can be characterized at different levels of the reproductive tract: the hypothalamo-pituitary axis, the ovarian axis, outflow tract abnormalities, and iatrogenic factors. And in cases where we have been able to identify at what point the cause of amenorrhea is, the treatment options could be reassurance, pharmacological approach like the use of drugs like bromocriptine and clomiphene citrate for induction of ovulation, or surgical intervention such as intrauterine adhesiolysis, laparoscopic ovarian drilling, and excision of pituitary adenomas. Thank you.